Hey, good afternoon. I'm Matthew Delaney. I'm an associate professor at the University of Alabama at Birmingham. We've got this great lunchtime picture here. We're going to be talking for the next 45 minutes on mesenteric ischemia. So high risks, pearls and pitfalls. I have no relevant financial disclosures. So there's really some good news when it comes to mesenteric ischemia, and there's some bad news when it comes to mesenteric ischemia. So we'll get the good news out of the way first. The good news is that the next shift I go to, the next shift you go to, the next patient you see in the clinic almost certainly doesn't have mesenteric ischemia. If we look at the epidemiology of this, only about 0.2% of patients who have abdominal pain are actually going to have mesenteric ischemia. Now, if you look at patients who are sicker, so if we use kind of the term an acute abdomen, which means we push on their belly, we're worried, and we say, yeah, I think something could be going on here that could be surgical, still patients with mesenteric ischemia really only account for about 1% of the patients. So if we're in Las Vegas and we just want to roll the dice, the chances are that the very next patient we see won't have this disease. And that's really the end of the good news, because the bad news is that in that subset of patients, in that 1% of patients who have an acute abdomen, or the 0.2% of patients of all comers who show up with belly pain, if they have mesenteric ischemia, the mortality at best is around 50%. So this really, when we're talking about things that can go bad within someone's abdomen, is a bit of a needle in a haystack. But if you step on that needle, or if we fail to see that needle, that can actually be a really, really bad player. And this is borne out in the medical literature. So the literature is a little bit messy, and we'll go through some of the gaps in terms of what we don't get from the literature. But if we look on almost 25% of the cases where a patient ends up having mesenteric ischemia, it wasn't suspected. So it doesn't mean we didn't look at the patient and say, this patient seems really sick. But when retrospectively we go back and ask the clinician, did you think that this was mesenteric ischemia? 22% of the time they say, that wasn't even on my differential. And so as we talk about this, I think one of the big keys to not missing this is to always pause and think, could this be that patient? Could this be that needle in the haystack that actually has underlying mesenteric ischemia? I'll be honest, I wasn't a great anatomist in medical school, and so in the process of trying to understand this disease and figure out how can we catch this disease more readily, I think going back through some of the basic anatomy actually can be pretty helpful. So the literature interchanges a bunch of words. So typically they'll say AMI for acute mesenteric ischemia. Really what we're talking about in about 98 to 99% of cases is acute arterial mesenteric ischemia. So if you pull up a paper or look on UpToDate, it'll say AMI, but typically they use acute mesenteric ischemia interchangeably with arterial mesenteric ischemia. If you look at why are folks getting these arterial occlusions, it's an embolus about 40% of the time. It's an acute thrombus about 40% of the time. And if this sort of sounds like other clotting diseases, this sounds like heart attacks, this sounds like strokes, non-occlusive, so whether it's an embolus or a thrombus, if it's not fully occlusive, that's about 10% of the cases. And then partial, which there's a lot of overlap in the literature between these non-occlusive and these partial cases. But think about patients who are going to form an embolus. Think about patients who are at risk to form a thrombus. And those are the patients we really need to stop and think, could this be mesenteric ischemia? Venous occlusion is out there. It's very, very poorly understood when it comes to the literature. So we think it accounts for about 2% of the cases. Typically, these patients have lower morbidity and lower mortality compared to the folks who have an arterial occlusion. Typically, the clues here are going to be this is a patient who has some reason why they would be hypercoagulable. With the venous occlusions, there's often a delay. So typically, we expect the patients had symptoms for about 2 days before that they present to be evaluated, where when you have an acute arterial occlusion, typically that's a much more acute kind of presentation in terms of the time period from when I first had symptoms to when I decided to seek care. CT scan is good. We'll talk about imaging for arterial occlusions. But if we look at how do we pick up venous occlusions, typically a CT with contrast that gets the venous phase is going to help us make this diagnosis. If you have a high index of suspicion, and honestly these patients are rare, you could go your whole career and never have a patient with a negative CT, but you still think there's a venous occlusion, MRI is going to be a little bit better of a test. And typically these patients are non-operative patients. So if you stumble into this, if you get a CT with contrast and it reads as there's a venous occlusion, you're going to treat this like other venous occlusions, and you're going to give them systemic anticoagulants. So really when we're thinking about what's the big bad player for mesenteric ischemia, it's AMI, so acute arterial mesenteric ischemia. The anatomy, the mesenteric gets confusing if you don't deal with this on a daily basis, but really when we're thinking about what do we need to know, the clinically relevant anatomy, we can walk through it because there are only a couple spots we really need to worry about. So kind of going from the head to the toes down the aorta, the first branch point is going to be the celiac comes off. Anatomically, this is rarely affected. So the celiac is hard to clot off for patients. And if you look at the celiac, so this is going to give blood flow to the stomach, to the spleen, and to the liver. So it's actually very good that this is not the vessel that most likely occludes, because it's certainly powering some high-priced real estate. The superior mesenteric artery, the SMA, is the one that is almost always or certainly the most likely vessel to clot. And we think that that's due to a couple of factors. The big one is just mechanical. So if you look at the aorta, the SMA comes off at a 45-degree angle. And that's kind of the perfect setup for if you have an embolus to kind of get wedged in there, just because it's got that sharp angle, it's got to go around. When we look at what does the SMA supply, the inferior pancreaticoduodenal artery, and then you're getting the left side of the digestive system and the right side of the digestive system. So you get the jejunum, the ileum, and then the ileocolic, the right colic, and the middle colic arteries. So the SMA's got this 45-degree takeoff. It's at risk for clotting just because that's a place where blood can get congested. And it's going to supply a large part of the digestive system. So this, if you think AMI, think SMA is the spot that's most likely to get clotted off. The inferior mesenteric artery, the IMA, it's rarely involved. It's a smaller caliber. And typically, I think of this is going to supply predominantly the left side of the digestive system, the left side of the colon. So celiac is there. It can clot. It doesn't often clot. SMA is the most likely to clot. And then IMA can clot, but like the celiac, is a lot less likely to actually clot. One of the things that's helpful is that the body has a lot of built-in redundancies. So when we're talking about blood flow to the mesentery, blood flow to the digestive system, the collateral flow is really important. So everybody, or almost everybody, has the marginal artery of Drummond. And what this does is this gives us collateral flow through the mesentery from the SMA to the IMA. So you may have a patient who has an occlusion, a partial occlusion, or even a complete occlusion in the SMA, but yet they're not showing signs of fulminant ischemia. And this could be because they have this resilient marginal artery of Drummond. So they're getting some flow between, kind of covering these watershed areas through these collaterals. There's an arc of Ryolan, which is not a fantasy novel. It's actually just a description based on some French anatomist, and that this is an extra layer of redundancy that about 10% of people have. I don't know, I don't ask patients routinely, do you have an arc of Ryolan? But I think it's helpful in the back of our minds to think you could still have some occlusions that could set you up for a problem, but you could kind of chugging along based on your collateral flow, which is going to give you some, at least a short-term bridge to warding off ischemia. That's the vascular anatomy. And then in terms of the part of the digestive system that's most likely involved, the middle jejunum, and again, remember, that's where the SMA is going to perfuse predominantly. This is typically your classic watershed area. So when you're looking at the middle jejunum, you're farthest from all your collaterals. So it's not that you can't get blood flow there, but really, if a patient's going to have decreased blood flow, it's likely going to affect the middle jejunum. One of the problems about this disease, and we see this across the literature, whenever we're looking at a disease that is fairly rare, and certainly acute mesenteric ischemia, fortunately, is a fairly rare disease, what we end up with is a lot of anecdotes and a lot of, hey, I saw this once, or somebody in medical school told me to look for these things, and then that gets kicked down the road and perpetuated. And so when we look at how do we make the diagnosis of mesenteric ischemia, there are a fair amount of kind of myths or things that are said with really no literature to back them up. One of the things is that very clearly, the history that a patient gives us, the history that we get from a patient and the patient's physical exam are pretty unreliable to the point of being almost dangerous when we're trying to risk stratify a patient in terms of could you have acute mesenteric ischemia. One of the things I was always taught was, well, patients will report postprandial pain. Best I can tell, there's really no literature basis to support this in terms of does this help us rule the disease in or rule the disease out. If we think about it, most of us eat 2 to 3 times a day. So we're always sort of postprandial in some regards. So if a patient tells me they have postprandial pain, that doesn't move my diagnostic needle. I certainly would be hesitant to rule out a case of mesenteric ischemia because it wasn't postprandial. And again, this is often taught, this is often repeated, but we don't have good high quality studies to say, yes, that's actually something we should clue in on. Pain out of proportion to exam, again, we say this all the time. The problem is when we try to quantify, what does that actually mean? I believe it when I see it. If the patient's acting really uncomfortable and I push and they don't seem to move much, but from a scientific standpoint, we have no idea, is there any inter-rater reliability? What actually are we describing? And so this gets said a lot. I've been asked this by consultants when I call and say, hey, I got a patient I'm worried about. Well, do they have pain out of proportion to exam? It certainly is something we see with cases of acute mesenteric ischemia, but it's the lack of this certainly doesn't let us rule this out. And then when it comes to ruling it in, again, it's a very subjective description that we put a lot of stock on from a diagnostic standpoint, which probably isn't helping us catch these cases. The exam is also unreliable, and the problem is it's not that the exam can't help us find a couple of these cases. So if you have a patient who comes in and they've had an out-of-hospital cardiac arrest, they've gotten a couple rounds of CPR, and they start to have bloody diarrhea after they get a return of spontaneous circulation. Yeah, I mean, that patient certainly, that exam, the fact that they now have gross hematochezia would make me think, hey, maybe something's ischemic within their gastrointestinal system. But the problem is, in that instance, we've already got evidence that they've infarcted their bowel or that their bowel is certainly ischemic. And so it's really one of these cases where if our exam points us in the direction, the train has already left the station. So the other instance would be if somebody comes in and they have, acute worsening right-sided abdominal pain with diarrhea. That exam would make me concerned. That story, that report would make me think, hey, that could certainly be consistent with acute mesenteric ischemia. But again, if we're seeing physical exam findings or something in the story that's really obvious, it screams mesenteric ischemia, the worry would be we've already missed the chance to make an intervention and preserve that patient's bowel viability. And so that's the problem when we look at how well the physical exam findings in conjunction with the history help us make this diagnosis, is that, yeah, we can pick up the really sick patients, but those features don't really help us find the patients in that acute phase where we really can make an intervention that could make a difference. So it seems like a dire world. Again, it's a rare disease. It's a disease that often will present atypically, and a lot of what we've been taught doesn't really seem to help us make the diagnosis. But going through the literature, there really seem to be 4 points that I think if we focus on these, this can help us risk stratify patients more accurately and hopefully catch a couple of these cases before patients have really bad outcomes downstream. So the first is to judge a book by the cover. The second is that we need to really wrap our minds around the idea that typical labs, the things we've been told to get if we think about mesenteric ischemia, really aren't reliable. The third is when we're imaging a patient for acute abdominal pain and we think there's any chance they could have acute mesenteric ischemia, we need to get a CT angio of their abdomen. That should be the first test we get. And then if we catch a case of this, the most important intervention is probably that we need to pick up the phone and call a friend. So we'll go through these 4 tips that I really think can help us make this diagnosis more quickly and more accurately for our patients. The first is to judge a book by its cover. And so we do this on a subconscious level in terms of what's the pre-test likelihood that a patient could have the disease we're thinking about. And for a lot of us, this is an automatic process. If you've done this long enough, you walk in the room, I think I've got an idea of what could be going on. I think I've got a pretty good gestalt about what's not going on. But when we're looking at a patient and we're thinking, you've got belly pain, could this be acute mesenteric ischemia? The question we need to ask ourselves is, are you somebody who likes to form clots? Is there a chance that you're going to form a clot and that's going to set you up for mesenteric ischemia? And this is fairly intuitive, but I didn't really think about this until I really sat down and drilled down in the literature. So if you've had a previous heart attack, if you have peripheral arterial disease, if you've had a stroke, if you've had a previous PE or DVT, all of those are readily available pieces of information that could make us say, hey, at some point in the past you've had trouble with blood vessels, and it sounds like you've had trouble with clots in all likelihood. So a patient with belly pain who's got a history of peripheral arterial disease, in my mind, has a much higher pretest probability than a patient who just says, I have no past medical history, but I'm having a little bit of right-sided abdominal pain. Embolus is, again, one of the leading causes of acute mesenteric ischemia. One of the things that's very clear is that there's a strong association between cases of mesenteric ischemia and then the patients with a history of atrial fibrillation. So up to 50% of patients with acute mesenteric ischemia will either have current or have a history of atrial fibrillation. Certainly a flutter, other dysrhythmias, I think would have a similar heightened risk. But I'm looking at you and you have this history of dysrhythmia. I gotta think, in the setting of the story of belly pain, could this be acute mesenteric ischemia? Age gets talked about a lot. Age pops up in a lot of the review articles and a lot of the kind of guidelines. And it's not that age isn't associated with an increased incidence of acute mesenteric ischemia, but unfortunately it's not that helpful. So the average age of a patient with acute mesenteric ischemia is 74. Women account for about 70% of these cases. But the reason that I don't think that is necessarily that helpful is that if you look at the incidence of bad things that happen in someone's abdomen, the numbers are always going to be higher in patients who are elderly. And so sure, an elderly patient has an increased baseline risk of developing acute mesenteric ischemia, but not being elderly is not protective, doesn't rule this out. So elderly abdominal pain, we should just generally think the chance that something bad is going on is higher than in somebody who's younger with similar risk factors. But this exact association between age and mesenteric ischemia isn't as robust as we'd like. So think about, are you likely to form a clot? Do you have a history of dysrhythmia? And then elderly will move my needle some, but it's not as crisp as we'd like necessarily. One of the other things that we don't often talk about is to look at a patient and think, do you have a low flow state? So I take all those other risk factors, and then I think about things like, do you have a history of heart failure? You know, if somebody doubled up on a diuretic, they might have a low intravascular volume, and that could set them up. In particular, you think about these kind of non-occlusive or partial occlusions. When they're euvolemic, they're doing fine, but you drop their kind of circulating volume, it'll actually become symptomatic from a mesenteric ischemia standpoint. In any cause of hypovolemia, if somebody starts throwing up a lot or has a foodborne illness and has a bunch of diarrhea, we gotta think, does that low flow state set you up to have mesenteric ischemia, and incorporate that in our risk stratification process. One of the groups of patients that I think is really concerning is patients who have a history, specifically a recent history of endocarditis. And so if we look, the complications, obviously we go for hours about the complications that we can see with infective endocarditis. And in the area of the opioid epidemic, we're seeing a lot more patients who either have a diagnosis of endocarditis or certainly have risk factors for having endocarditis. And a lot of those patients are coming in, they may be intoxicated, they may be withdrawing. These can be challenging patients to care for. But in that patient population, anybody who's used needles, we have to really stop and think, with a story of abdominal pain, could this be mesenteric ischemia? Because what we know very clearly, if we take patients who are formally diagnosed with infective endocarditis, 20% of these patients over the course of their treatment are going to be diagnosed with acute mesenteric ischemia. This is from a couple of studies, fairly small numbers, but that's the second leading complication from infective endocarditis, second only to stroke. And so if we see a patient and they've got abdominal pain, certainly if it doesn't fit into any other kind of diagnostic category, we really have to stop and think, does the fact that you've used IV, the fact that you've been an injection drug user or gotten tattoos with unclean needles, does that set you up to get endocarditis? And would that subsequently set you up to have acute mesenteric ischemia? So this is typically not the mold of the patient who's got peripheral arterial disease, AFib, advanced age. So these are younger patients with fewer comorbidities who are at risk. And the problem is, if we really look at when does this break loose, the most common time period when a patient with infective endocarditis will get acute mesenteric ischemia is actually 2 to 4 weeks after starting treatment with antibiotics. And so we had a patient a couple years ago who had come into the hospital, was diagnosed with infective endocarditis, had been sober for 3 to 4 weeks, had a PICC line, had gone back to their house. And so they came in, they didn't have any of the stigmata we typically associate with someone who's really wrestling with an opioid addiction right then. And they had a PICC line, they were getting their antibiotics, and they actually had acute mesenteric ischemia, and they were in that window of 2 to 4 weeks after starting antibiotics seems to be the risk period. So think about risk factors. IV drug abuse is a huge risk factor for endocarditis. That subsequently is a risk factor for acute mesenteric ischemia. So we got to keep those people, and again, that's that judging a book by the cover. Think about, is something going on in this patient's world that's going to increase the chance they form clots? Typical labs are overrated. So the classic teaching has been that patients with acute mesenteric ischemia are going to have a leukocytosis, and then they're going to have an elevated lactic acid and have a lactic acidosis subsequently. And the problem is that some of this is true, but it's certainly been overstated in a lot of the sources we have to date. So if we look, the traditionally reported performance of lactic acid is pretty good. So it's reported as being 96% sensitive and 38% specific. Sure, I don't really care about specificity, but that seems to be a very robust sensitivity when it comes to, if I check this in a bunch of patients, how am I going to miss cases of mesenteric ischemia if it's that sensitive? The problem is that that's the bottom line that gets put out there. So this is how good lactic acid is in terms of making this diagnosis. But then we have to kind of look at where we came from, because it's a weird path that's led us to that reported test performance. So initially, we kind of backed into this. So the initial studies were looking at patients who had big intra-abdominal surgeries or spinal surgeries, who had what they'd call intestinal vascular occlusions. So they'd be doing something, there would be either a misadventure or something with the technique, and then they would say, yep, something is wrong with their intestines. Somehow the vessels have been affected, they've had this intestinal catastrophe. And they said, well, hey, look, if you look at those patients, and you check a lactic acid, it's higher. So it's actually, if you've had some intestinal vascular occlusion throughout the course of an operation, you may have 10 times the number, your lactic acid may be 10 times higher than somebody who didn't have that. So out of the surgical world, decades ago, we started to say, okay, there's something there with vascular issues in the abdomen and elevated lactic acids. And so then it goes back into this somewhat odd world full of misadventures with animal models. So the initial theory was, okay, we know that it's something with the vasculature in the abdomen. I bet it's specific to the SMA. That's the most at-risk branch point off the aorta. We know that that's not true, but that was the initial thought was, well, this is a problem related specifically to the SMA. Then there was thought that if the gut was hypoperfused, so not ischemic, but that if the gut started to get a little lower circulating blood volume, that the gut specifically would emit lactic acid. We know that's not true. And then all of this kind of distilled down, even though these things were disproven, a lot of what was put out there was saying, look, we may have been wrong at first, but what seems to be very clear is that lactic acid, if checked early, so if a patient has abdominal pain, they come in an hour or two later, that lactic acid is going to be helpful in terms of identifying cases with acute mesenteric ischemia. So that's kind of where we came from. The other thing in terms of not only are the foundations that have led us to this idea that we should use lactic acid problematic. If we look at the test performance, we'll talk about sensitivity, but the specificity is all over the place. So if we check this in every patient, we're going to get a lot of false positives. So there's studies out there that show for patients with decompensated cirrhosis, the incidence of having an elevated lactic acid is near 100%. If you take patients with bowel obstructions, the incidence of having an elevated lactic acid is about 50%. If you have cirrhosis, not any kind of decompensation, just have a history of cirrhosis, 33% of the patients who are not symptomatic are going to have an elevated lactic acid. So the idea that we could just throw out lactate and precisely identify patients who have mesenteric ischemia doesn't hold up. The specificity just is really poor. Again, when we're talking about how do we catch a disease, sensitivity is something I'd look more to, because I don't want to get a false negative. There are studies out there that do say, no. In our case series of patients with acute mesenteric ischemia, lactic was 100% sensitive. The problem is if you go to those studies and really try to look, who are these patients? These are critically ill patients with mortalities upwards of 70 to 80%. So sure, if you go to an ICU full of patients who are dying from acute mesenteric ischemia, there's a good chance that most of them are going to have an elevated lactic acid, but that's very different than the 55-year-old with paroxysmal AFib that shows up in the emergency department with some abdominal pain. In those patients, we would expect that the lactic acid is not going to be present in 100% of the time. In fact, Acosta et al. In 2011 tries to answer that question. It's a small number of patients, but they found that out of 27 patients with acute mesenteric ischemia, only 12 of the patients actually had a normal lactic acid. And this was on patients who were seen on an urgent or emergent basis. So the patient walking in who says, hey, I've had AFib in the past, I have dyslipidemia, my belly hurts. If we rely on lactic acid to identify the presence of acute mesenteric ischemia, we might as well flip a coin. This is not a test that reliably helps us identify these patients. The problem is when we really try to drill down and say, okay, what's the actual how well does this actually perform? The overall numbers are too small to get a really clear conclusion in terms of something like a likelihood ratio, positive likelihood ratio, or negative likelihood ratio. And so the way that I kind of think about it, and the level of evidence that we have is that there are going to be patients with acute mesenteric ischemia who show up and have a normal lactate. It's not a reliable test to help us pick up on these patients. And again, if we take all of the patients with mesenteric ischemia, including the sick ones, sure, we can expect that the sensitivity is going to be higher, but just know that there is certainly a chance that the patient in front of us who has acute mesenteric ischemia could have a normal lactate. And that's just that patient's unlucky number has come up, and that test is going to contribute to the fact that we misdiagnose these patients or miss the chance to get these patients better. Lactate is not totally useless when it comes to working these patients up. One of the things that's very clear is that lactate is much more powerful when it comes to prognosis. So it's prognostic rather than diagnostic, meaning that if we're using it to look at a patient, if a patient comes in and the lactic acid is 11, and we think they have mesenteric ischemia, that actually portends very bad things happening. Now, we don't have great high quality, we don't have a ton of numbers in terms of for each percentage point that the lactic is elevated, the patient's survival goes down by a certain percentage point, but very clearly there seems to be almost a near linear relationship between the higher your lactate is, if you have mesenteric ischemia, the higher your mortality is going to be. So if we're looking at a patient, and I've had surgeons look at patients and say they have mesenteric ischemia, their lactate is 14, the horse is very much out of the barn, and this is a patient who has a low chance of surviving, and that seems to be reliable. So if we're using lactates, I'm not opposed to getting them. I'll actually get these in a lot of patients if I think they have mesenteric ischemia, but really the power seems to come from the prognostic value. Yes, this is very worrisome, or if it's normal, even with imaging that could be concerning, hey, maybe we've caught this at a spot where we could still make a meaningful intervention for the patient. Another test that's out there is D-dimer. D-dimer, in terms of catching cases of mesenteric ischemia, actually makes some sense, right? We use it to check for other clotting diseases. So we all know how to use it for trying to work up a pulmonary embolism or a DVT. So do we have any evidence to say that this would work in terms of, I look at a patient, I don't know what's going on, I think, could this be mesenteric ischemia? Is there any role for D-dimer? And the answer seems to be maybe. So the animal studies are strange. So this was a study where they took rats and they ligated the SMA and compared them to a control group. And so they said, let's check a dimer at hours 1, 2, and 3. And what they found, obviously, was if your dimer was elevated, that you had a 36% increase in the rate of AMI. So this was a positive study to say, yeah, look, if it's elevated, we should be more concerned for mesenteric ischemia. This study is confusing, and I think gives us reason to kind of pause and think about the role that dimer could play. So a similar animal study, and they did an X-lap on rats. And they put them into one of 3 groups. So either the SMA was seen, so they just opened the rat up and said, we see it, close the rat, and we're done. They opened them up, and the SMA was manipulated, so they just kind of mucked around with it, didn't ligate it, didn't cut it, but just moved it around some, closed them up, and we're done. And then in the third group, they opened them up, they ligated the SMA, then closed them up. And so what they checked is D-dimers and lactates at hour 1, 4, and 6. And what they found is that the D-dimer really wasn't helpful early. Even when you got to hour 6, they really couldn't separate out these 3 groups. But they did find that by hour 4, you could start to differentiate between the groups. And again, this is getting more into the prognostic phase, because if you're 4 hours into your SMA being ligated or fully occluded, obviously there's going to be some underlying damage there. So D-dimer wasn't as helpful in this animal study as other studies may have shown us. But we're not dealing with rats, we're dealing with people. So what do we have in terms of human data? So Sun et al. 2017 had a meta-analysis of 12 studies, about 1,300 patients. A little bit of a messy inclusion criteria. So 8 studies looked at patients, 8 of the included studies looked at patients just with acute mesenteric ischemia. 2 included patients who had incarcerated hernias, and 2 had just other abdominal catastrophes. So a little bit of a messy, kind of set of ingredients they're putting together, but fairly decent numbers. And what they found is overall, when it comes to D-dimer, the sensitivity was 94%, specificity was 50%. And then likelihood ratios, and remember, when we think about what's a good positive likelihood ratio in terms of ruling something in, and what's a good negative likelihood ratio in terms of ruling something out, we'd like to see a positive greater than 10. So 1.9 doesn't move my needle. I'm not gonna, if the D-dimer is positive, I'm not gonna be too much more concerned. But when we look at that negative likelihood ratio of 0.12, that's actually something that I think could play a role in some patients. And so again, not the highest level of evidence, actually the highest level of evidence we have looking at D-dimer in these patients. And that's a pretty good negative likelihood ratio. One of the issues that comes up is what cutoff did they use? So if we look at that meta-analysis, the 2 biggest prospective studies were Acosta 2004, Ding 2007, and in total, this is 300 patients. And what they found was they both used a cutoff of 300 micrograms per liter. And this is also the same as a nanogram per milliliter. So when you look at your D-dimer, if it's 300, that's the cutoff they were using, whereas for PE, we typically use something like a 500. And they said that, that was their cutoff to generate those likelihood ratios. They said the older you get, the more likely or the higher the average D-dimer is going to be. And that's something I think we all are familiar with when it comes to working up other clots. But there was no data here on adjusting for age. So if you have a patient where you're thinking, hey, I'm going to get a D-dimer, I don't know exactly what's going on, 300 would be the cutoff to use. Labs for acute mesenteric ischemia, again, history is not necessarily helpful. Physical exam is not necessarily helpful. In terms of labs, lactate is not helpful early. Very clearly, lactate doesn't help us sort out who has acute mesenteric ischemia versus another cause of abdominal pain. After 4 hours, so a patient said, I've had 12 hours of pain. If they have a normal lactate, you're going to see the negative likelihood ratio is going to be better in those patients. But the early presenters, the ones where we can make a meaningful intervention, it's not helpful. And again, it's a likely prognostic, not diagnostic. So if you have a patient who's been 12 hours since the onset of pain, their lactate's 12, that patient has a very high chance of having something bad happen. And I think that's a discussion to have with the patient, with the consultants about, really, are we too far down a road to do something meaningful in terms of improving the chance that you do better here? D-dimer, this is one of these things that doesn't feel quite ready for prime time based on the level of evidence. It's not clear that there's a lot of momentum to study this further. And so, we don't know how well this performs early. From the animal studies, it doesn't seem like this is going to be the test after an hour of pain with a normal D-dimer. Can we rule this out? But the further along we go, so if a patient's had 8-10 hours of pain, you think otherwise that there's a low chance to have acute mesenteric ischemia. There may be some role here for a D-dimer less than 300 in terms of decreasing the post-test likelihood the patient has an acute clot in the mesentery. So labs don't help us. Imaging, there's good news here. So if we see a patient and we think you could have acute mesenteric ischemia, or even there's a reasonable chance you could have it, I'm not convinced, but maybe that's what's going on, the test we need to get is a CT angio. And the reason here, CT angio arguably is the right test for anybody that we look at and we say, I'm concerned something bad is going on in your belly that could kill you. The reason I say that is if we think about what are things that can go on in your abdomen that will kill you, it's not typically appendicitis. It's not typically kind of a partial small bowel obstruction. It's going to be things like, do you have a AAA? Do you have an aortic dissection? Do you have a GI bleed? Do you have acute mesenteric ischemia? So a lot of the big bad players all have some kind of connection to the vasculature. And that's where CTA really has its diagnostic power. Other tests get pushed out as we could use these tests to avoid doing CTAs in patients. The problem is ultrasound, if we get a formal ultrasound done by a trained ultrasonographer for proximal occlusions and stenosis, so right where the vasculature comes off the aorta, the reported performance is pretty good, or it's pretty specific. It's not sensitive. So if you look, you get a report, yep, there's an occlusion in the SMA, that's probably right. But if you look and get a report that says there's no clot, that's not reliable. There's been a push in the world of emergency medicine to, hey, we should use bedside point of care ultrasound. Sure, if you go and get special training on how to do this and you see a clot, again, the specificity is probably fine. I am not comfortable doing that myself. I wouldn't use this to rule anything out on a patient, even if you're comfortable with the test. The only benefit really that seems to be reliable is that we can look at other things. So if you're good with point of care ultrasound and you want to look at the SMA or the celiac as it comes off, go for it. But I think the power in ultrasound is not making this diagnosis, certainly not in ruling out this diagnosis, but hey, I'm going to look for other things. I'm going to look at your aorta, make sure there's not a AAA, make sure there's not free fluid or anything like that. So ultrasound should not be the definitive test for the vast majority of patients if we think, hey, you could have mesenteric ischemia. MRI is good. All the studies for any disease process, the answer when it comes to MRI is, yeah, it actually works. It answers the question reliably, but it's hard to get an MRI done quickly, and I don't have access to an MRI. So if you're at a shop where you can get an MRI rapidly and the patient can't have a CTA, go for it. But again, for most of us, that's a pie in the sky idea that's going to be my first line test to work this up. CT angio, so I had a lot of misconceptions in my mind when it came to what do you get with a CT angio. And I always thought of it as like, I don't want to just pull the trigger on that. Like, well, I got to save that for the right patient. And I talked to a radiologist, and it's really a pretty simple test that I don't know why I had thought of as such this big to do. So what you typically will get with a CT angio is a couple of different things. So First off, you get a non-contrast scan. Now, some protocols have dropped this, but typically they'll get a non-con scan. And when it comes to an acute mesenteric ischemia, that doesn't often add very much from a diagnostic standpoint. But then after that non-con scan, which kind of gets a baseline and helps the radiologist down the road, you get one contrast bolus. But then you're going to get two scans. So you're going to get the arterial phase, and that's the vascular phase. You're going to get the venous phase, which lets you see the bowel. And so, and then what they'll do is they'll take these two scans, the arterial phase, the venous phase, and do these multiplanar reconstructions, which give them more diagnostic accuracy. And so I think what I had failed to appreciate is that for every patient where I send them to the CAT scan, I say I want a CT scan with IV contrast, and I'm concerned about appendicitis, small bowel obstruction. What they're doing is they're getting one contrast bolus, and then the tech is waiting. It's just a time thing, waiting through the arterial phase, and then once the contrast has been through the arterial phases and the venous phase, then they scan the patient. So really what I'm doing when I get a CT angio is saying, rather than just sit there while the contrast goes through the arterial phase, let's get a picture then let's get a picture as it goes through the venous phase. So it's not that getting a CTA obscures anything, and it's actually getting us extra information. And remember, that's because we're scanning during the arterial phase and during the venous phase. One of the things that comes up is, well, why do I need to get more? Is that in the patient's best interest to do more? And really, I've kind of reached the conclusion that it's a much more accurate test, and the risk associated with it is minimal. So if we look, there's a little more radiation. So the patients are getting scanned twice, right? They're getting an arterial phase scan, they're getting a venous phase scan. That's 1 to 10 millisieverts of radiation per scan. So yes, it's double. But that's that's a fairly low number. If you think the background radiation we get is 3 millisieverts per year. Obviously, I don't like the idea of exposing patients to more radiation, but these are typically patients who are older, so that radiation risk is going to be less as they go over the course of their life than it would be for a patient who's 8 years old. So a little more radiation. You get a little more contrast. So talking to the radiology techs, it's about 100 cc's more contrast in that bolus compared to if you just got a CT with IV contrast. So if you didn't order the angiography phase, for almost all patients that we see, that 100 cc bolus is not going to be the difference. That's unlikely to hurt most patients. But what we do get, so the trade-off is going to be, there's a little more radiation, there's a little more contrast, there's arguably, depending on where you work, a little more expense or cost charged to the patient. But the trade-off for that is we get a whole lot more accuracy because we're getting both the arterial phase and the venous phase. If we look, really getting those two phases seems to be important and help us kind of in combination, we get a very accurate test. So CTA performance, if we look just at bowel wall thickening, the sensitivity specificity is 88% and 70%. So this is if you're getting just a venous phase. The most common finding you're going to see on cases of acute mesenteric ischemia is going to be this hypo-enhanced bowel wall. They call it pale ischemia. So in isolation, you're going to see this about 88% of the cases. Interestingly, the performance for vascular occlusion, so looking in that arterial phase and saying, do I see a clot? Yes, no. Sensitivity is bad, so 12 to 25% with a specificity of 94 to 100%, right? So if I don't see it, it doesn't mean it's not there, but if I see a clot on the arterial phase, reliably, there is going to be a clot there. So you've got the bowel wall view, you've got the view of the actual vasculature, but when you combine them, so take those two findings and give the radiologist both pieces of information, the performance 97% sensitive, 100% specific. So CT angio, a little more radiation, a little more contrast, maybe a little more charge to the patient, but a much higher performance. One of the things that's really interesting is we struggle across the House of Medicine when it comes to diagnosing these from a radiology standpoint. So this is a study out of the radiology literature. There were 95 patients who had acute mesenteric ischemia. The provider only suspected it. So on the indication, they only mentioned acute mesenteric ischemia in 31% of the cases. And what that did was when they didn't list that as a concern, they often didn't get the right protocol. So rather than getting a CT angio, they got a lot of CTs with IV contrast, which again is a less accurate test. So the radiology takeaway was, I mean, you guys are kind of stumbling around out there. And if you're not thinking about it, if you're not listing it as an indication, the patients in this study were not getting the right test in a lot of the cases. One of the other really interesting things is also that there seems to be some value in talking to our colleagues in radiology. I understand, I like the idea that, well, they're paid to look at the study, and why do they need to hear, they always say clinical correlation anyway, why do I need to call them if I'm concerned? What this has pushed me to do is say, if I think they have mesenteric ischemia, it's probably worth talking to my radiologist, or at least putting on there, hey, I'm concerned that there's acute mesenteric ischemia. And what they found is that in cases where the clinician suspected, whether it was on the phone call or on the order, if they said, hey, I'm worried about acute mesenteric ischemia, the accuracy of the radiology reports was 97%. Where if you looked and there was no mention, the accuracy was 81%. And so they found that those patients where it wasn't mentioned, it was diagnosed less frequently, the report was less accurate. And also those patients did worse, they had a higher rate of bowel resection. So is this a perfect study? Absolutely not, but I think that this is a good reminder that this is a rare disease, that our tests aren't perfect, but that working in conjunction with the radiologists is going to help them make the diagnosis for the patient. Last step here, so if we get a case, so we don't trust our history, we don't trust our physical exam, we don't trust our labs, we get a CT angio, we make this diagnosis, that this is a patient who has acute mesenteric ischemia, what do we need to do? A lot of treatments have been thrown out there. A lot of treatments should be thrown in the garbage. So things like anticoagulation for acute arterial mesenteric ischemia, most of the data we have, most of the guidelines are pointing us away from that. There's an increased risk of bleed. There does not seem to be a consistent survival benefit. Vasodilatation makes sense. If your vessel is blocked up or sort of blocked up, if I can dilate your vessel, are you going to do better? It's a good idea that has not been shown to have any significant improvement in morbidity or mortality for these patients. Antibiotics are interesting. So a lot of the guidelines, a lot of the expert recommendations would say, yes, you should give these patients antibiotics. Strictly from it, does it help from a patient survival standpoint? It does not seem to have a survival benefit. The counter to that would be if you've got ischemic bowel, there's going to be a higher rate of perforations. Does it make intuitive sense to give this patient a dose of antibiotics? I understand the logic, but just if we're going from an evidence-based standpoint, we do not have good evidence to say that these patients need antibiotics. So that leaves us with, do we have the patient have an operation, or do we have the patient go to interventional radiology? And those seem to be the two interventions that we've got that, while they're not perfect, are the best chance we've got of improving the patient's outcomes. What do we know about how well does surgery work? We actually don't know a ton. There's certainly some limitations in the surgical literature, but it's very clear that the longer a patient waits to go to the OR, the higher their mortality is when we're dealing with acute mesenteric ischemia. So this truly is one of these diagnoses. If we suspect it, we got to get on this early. We got to get a CT angio. We got to talk to radiology, and if we make the diagnosis, we got to pick up the phone and call a surgeon. I've had cases where I've called a surgeon preemptively saying, look, I'm just really concerned. They got a lot of risk factors. I think something bad could be going on. Sometimes I'm right, often I'm wrong, and the surgeons will fuss, but if we have a case of mesenteric ischemia, we got to move quickly. Endovascular interventions, no matter what discipline is doing them, really have started to become a more popular first-line response to cases of acute mesenteric ischemia. Last study we had showed really there's an increasing popularity. We're seeing more and more endovascular interventions for a variety of diseases, specifically clotting diseases, whether it's a heart attack, whether it's a stroke, whether it's mesenteric ischemia. And so we're seeing the incidence of acute mesenteric ischemia handled by IR go from 12 to 30%, and that was in 2009. Those numbers are certainly going up. So depending on where you're working, you may have a system set up of, yep, if I have this diagnosis, I call IR first rather than I call surgery first. And a lot of that's just institution specific, because when it comes to the literature, it's not clear that either one of those is a preferred method. So this study was in 2012. The techniques have become better. The outcomes undoubtedly are better as the techniques have improved. We just don't have a ton of literature to back that up. But Ryer et al. In 2012 found that if you had acute mesenteric ischemia and you went to IR, got an endovascular intervention or a surgical intervention, that it worked in 87% of the cases. So the efficacy was the same, but there was a mortality difference. So endovascular reported a lower mortality compared to surgery. And I don't think that that's a real thing that we should necessarily focus on. Kind of intuitively makes sense. If you have a patient that comes in and they have mesenteric ischemia and they're so sick that IR is like, they're not stable enough to come to IR, obviously the only chance that patient would have is to go to surgery. So what we're likely seeing here is just the sicker subset of patients end up going to surgery. So if you have a patient, you make this diagnosis, and you're stuck thinking, should I call surgery or should I call IR? Both are viable options, and in places where I've worked, a lot of times I try to get everybody on the phone at the same time and say, this is what we've got. What do you guys think the next best step is? Because IR, surgery both seem to be viable options for these patients. So acute mesenteric ischemia, again, good news is you're almost certainly not going to see this on your next shift. The bad news is it's a very bad disease. It's a very bad diagnosis to miss. To catch this, we need to throw out a lot of what we've known historically, so we should judge a book by the cover. Are you someone who's formed clots? Do you seem like someone who would form clots? I always have to remind myself, think about IV drug use and abuse. It's certainly a growing risk factor for these patients. Labs are overrated. D-dimer may have a role if you get a negative D-dimer and a patient's had prolonged symptoms. That likely is giving us good information. Exactly how we use this is not necessarily helpful. Again, lactate is not going to help us catch the cases early. It may help us identify patients who are at an increased risk of having something bad happen from the acute mesenteric ischemia. If we're looking at a patient and we're thinking something bad could be going in your abdomen, and that bad thing could be acute mesenteric ischemia, CT angio is the test. It's much more accurate, and the trade-off is really minimal. And then if we get a case, again, I would pick up the phone, because whatever happens, whether that's IR or that's surgery, the quicker we can make that happen, the better our patients are going to do.
Okay. All right. Well, welcome to a talk. I gave a talk a little while ago, and this is going to be kind of a completely different topic. But my name is Chase Collier. I'm a maternal fetal medicine specialist at UAB. And we're going to kind of just talk pretty broadly today just about kind of medical complications in pregnancy, comorbidities in pregnancy, things along those lines. Basically things that make me have a job. And so the subtitle of this is really providing care for women with pre-existing medical conditions in pregnancy. I have no conflicts of interest to report regarding this presentation. So if you look at this is a lot of things that we could cover. And I know about you, I definitely don't want to talk about all of these things. I don't think you want to listen to me talk about all of these things. And so really, kind of when I thought about talking about these comorbidities of pregnancy, I really was like, what does just a general physician, general primary care provider, or even subspecialist that deals with pregnant women really need to know? And so kind of what I want to focus on is really kind of this idea of just optimizing medical conditions before pregnancy. And so like kind of a better topic is I just want to talk about the most common pre-existing medical conditions prior to pregnancy. And so we're going to talk about some pregnancy physiology, talk about some other things, but just kind of just some education for today. So kind of I hope that you can understand these things at the conclusion of this presentation. I'm going to talk about just some physiologic changes in pregnancy. I think many of these you'll be aware of, many of these you may not, but in order to understand a pregnant woman, you have to understand the changes that are happening for her physiologically. I want to talk about just the most common pre-existing medical comorbidities and really what those pregnancy risks are and why we really do want to get a hold of those before a woman gets pregnant. We want to talk about how a woman with these medical comorbidities are counseled because they're going to be on medication during pregnancy and how we counsel them. I want to talk about hope you'll understand the role before and after pregnancy in women with pre-existing medical comorbidities, whether you're an obstetrician or whether you're not. And then just kind of, I want you to understand that when we're dealing with these women with medical complications, that this really is a team game. It's not just us. It's not just us as obstetricians. It's everybody that takes care of this woman before pregnancy and after pregnancy. Because ultimately what we want is not just a healthy mom, healthy baby, but we want a healthy mom, healthy baby, healthy family. So this is kind of what everyone thinks about whenever they think about, I want to get pregnant. They imagine having a baby in a beautiful sunlight, holding it up high up in the air, and just that baby just smiling and laughing. And the truth is, this is, you know, I don't know how many people are able to throw a baby up in those kind of weeds, but this is kind of what what happens for many women. But the truth is, a lot of the times we have this. We have a very sad situation. We have a woman who underwent some kind of very complicated pregnancy, and they need support. And even though, fortunately, this is not the majority, but unfortunately, this is much more common than really people want to realize. And so the question is why? Why is not every pregnancy go exactly the way we want it to? Well, there was a movement in my field about 10 years ago, and it really shed some light into kind of this idea of pregnancy as a window into a woman's future health. And so the premise is basically that these pre-existing predispositions that all people have, and specifically women have, that are associated with long-term chronic disease, they are unmasked during the physiologic stressful state. And for most women, that first physiologic stressful time is pregnancy. Because what I tell women all the time is pregnancy is a stress test. And what happens is most women handle this very well, but a lot of women who have these underlying genetic predispositions, familial predispositions, they can have these adverse outcomes. But more so is that women that already have these chronic conditions, that already have, you know, things we're going to talk about, obesity and high blood pressure, they don't need unmasking because they've already been unmasked from their stressful situation. And basically when pregnancy does occur, the added stress can often lead to even more adverse pregnancy outcomes. And so this is just an idea that I've kind of, we've kind of developed, is just this pregnancy is a catalyst to worsening health. For women that already have predispositions, pregnancy ain't gonna make them any healthier and potentially is gonna hasten and worsen their chronic medical condition. So in order to talk about this, let's just briefly talk about a little bit of the physiology of pregnancy. So just in general, the energy demand that is needed increases by 20%. And for those with multiples, it's 30%. For those with triplets, I just saw a set of triplets earlier today, it's upwards of 40%. And so it's no wonder when I talk to my triplet mom, I say, how are you doing? She goes, I'm exhausted. And the reason why is because her body is just demanding so much energy or consuming so much energy in order for it to just function and carry on its normal metabolic activity. And so in order to meet these energy requirements, the body must compensate. And there's multiple ways that we're going to go into details with about how the body does that. So in general, the average weight gain of pregnancy is about 27.5 pounds. Well, no one gains 27.5 pounds. It's just the average. Many women gain less than that, 10, 12 pounds. Many women, and I'm not ashamed to say family members I'm close to, can gain upwards of 80 to 90 pounds. And so it's very common for women to gain all sorts of weight throughout pregnancy. The majority of the time, this average weight gain is due to just natural expansion, just physiologic expansion, getting bigger organs such as the uterus, the blood volume increasing, the fetus developing inside, and the placenta developing. There's also, because of this weight, there's also a hyperlipidemic state. Triglycerides are going to increase. Cholesterols are going to increase, both HDLs and LDLs. So if you get a cholesterol panel on a pregnant woman, it's going to be high, and that's okay. You're going to have an increased insulin resistance. This is because the body's going to need to consume more glucose, and so it's going to have higher glucose levels. So this is going to lead into a hyperinsulinemia. Unfortunately, that hyperinsulinemia is going to correct itself at certain times in fasting states. And so because of that, you're going to have a lot of insulin circulating, and you're going to get hypoglycemia. But what's crazy is that the body is so in tune and responsive to this that when you eat, they're going to make even more insulin, and so you're going to get a postprandial hyperglycemia. And so this is very, very normal pregnancy physiology. And really, when you talk about what happens, this is all due to progesterone. Once you have a fertilization of the egg and you have development of the zygote, immediately the corpus luteum, which is what the ovulation turned into, is going to start producing massive amount of progesterone to facilitate these changes. And then once the corpus luteum resolves, the placenta is going to take its place and produce lots of progesterone to keep these pregnant physiologic states intact. And so what happens when you have massive amounts of progesterone? You have increased blood volume. Not just of you have increased blood volume, just total blood volume of both your plasma and your red blood cells. But typically there tends to be a higher plasma blood volume increase than RBC. And so this is going to result in a decreased hemoglobin. So it's not going to be surprising if you see a pregnant lady who actually looks anemic when actually that's pretty physiologic. You're going to have an increased vasodilation. Progesterone is going to decrease systemic vascular resistance, and this turn is going to lead to decreased blood pressure. Now, we'll talk later on how you'll actually have increased blood pressure later on in pregnancy, but overall, it's more of a decreased blood pressure state. It's going to have increased heart rates. Typically 100 is in the upper limits of normal, but just today, I saw 9 patients this morning. Only 2 of them had heart rates under 100. The rest were in between 100 and 110, and that's normal physiology. You're going to have increased cardiac output. This is just because these blood volumes are increasing, and so therefore the cardiac output is automatically going to be increased. That's going to put more stress on the maternal heart. Well, what's even more encouraging, but also more worrisome in some of our really complicated pregnant women, is that when they're actually pushing in labor, which is incredibly strenuous as far as just witnessing it firsthand for many, many years, is that cardiac output is actually going to increase over 50%. So it's going to be at 150% of its normal baseline. Okay? You're also going to have this hypercoagulable state. This is because most of your factors that are prothrombotic are going to increase. Your fibrinogen is going to increase. Your D-dimer is going to increase. All of these factors are going to increase. a few of these factors, 11 and 13, and then your protein S that are more prothrombophilia are actually going to decrease. And so you're going to just have this hypercoagulable state and increased risk of blood clots. You're going to have some respiratory compensation. You're going to have an increase in minute ventilation. And because of the diaphragm pushing down, you're going to have a decrease in functional residual capacity. Other markers are going to stay the same, but just because of that increased minute ventilation, you're going to have quite a few changes, especially on your ABG. You're going to have an increase in PaO2 and P big AO2. But then you're also going to have a decrease in your PaCO2. And that's going to lead to some other things we'll talk about. You're going to have an increase in renal perfusion. Just blood in general is going to increase, and so more blood's going to go to the kidneys. The metabolic demand is increased, so it's going to have to regulate higher. So pregnancy is very stressful on the kidney. That's going to result in an increased GFR, and anytime you have an increased GFR, you're going to have a decreased serum creatinine. Anytime that I see a creatinine over 1, I know that's abnormal. And really, if it's over 0.8, that's something that kind of catches my attention, that this lady probably has underlying kidney disease. Because of this increased GFR, you're going to have an increased excretion of a lot of these metabolites. You're going to have increased sodium excretion, which is going to lead to hyponatremia. You're going to have increased protein excretion, which is going to lead to what looks like a proteinuria state. Now, there are levels to where too much protein too much protein in your urine is abnormal, and that's a great way that we diagnose things like preeclampsia. But a little bit of protein in your urine is normal for a pregnant lady. A little bit of glucose in a pregnant lady is normal. Now, not 4+ on a dip, but a little bit's okay. Bicarb is going to be low, and this is basically because it's going to be a respiratory compensation for what's turned into a respiratory alkalosis. As I mentioned earlier, when a mom is minute ventilation's up, they're releasing a lot more CO2, so their PaCO2 is going to go down. Well, in order to compensate, their bicarb is going to go down in order to act as the buffering system. So, and what I always want to mention this when I'm talking to non-obstetricians, if you see a normal pH in a pregnant woman, that's abnormal, okay? All pregnant women are going to have a little bit elevated pH just because of this normal respiratory alkalosis. So a normal pH in a pregnant woman is abnormal and needs to be addressed, okay? Other lab changes, they're going to have increased white count. They're going to have some decreased platelets, but they're going to have an increased alkaline phosphatase. Now, just because these are adjusted doesn't mean that these extreme values are normal. And so it's just basically the goalpost, to use a football term, has been moved in order to demonstrate normal versus abnormal. So what are some of these common conditions seen in pregnancy? And really, I want to talk about just what I call the Mfm Triad, because at least 50 to 60% of my patients have the following things. Have all 3 of the following things. And probably 75% have at least one of these things. So first is just obesity. I don't need to spend too much time about it, but I do want to talk about just the pregnancy implications of obesity. Definition-wise, we use the same definition that's recommended outside of pregnancy. The difference is we base this on pre or early pregnancy BMI. Clearly, moms are going to gain weight in pregnancy. Their BMI is going to go up. That's not abnormal. A woman who starts out with a BMI of 24 but gains 25 pounds and gets up to a BMI of 30, 31, they're not obese, okay? That's very physiologically normal. But if they start out at 35, well, that's abnormal. They've reached obesity class 2 and something that needs to be addressed and talked to them about as far as problems with obesity and pregnancy. Okay, and you can see the last category, super morbid obesity, BMI of greater than 50. Sadly, this is probably about 5% of my patients. This is incredibly common in our patient population here and in women of reproductive age that are actually pregnant. And you can see here approximately 1/3 of patients have BMIs already greater than 30. This isn't pregnant patients, this is just women that potentially could get pregnant. So it's incredibly disheartening when you look at all of the complications that can be associated with obesity. And just like anything, or just like a lot of things, the higher the BMI, the higher the risk of adverse pregnancy outcomes. So this is very much on a continuous continuous spectrum to where women of BMIs of 60 are even at higher risk than BMIs of 45. And so that's kind of that. Obesity, you have long-term risk of pregnancy. So whenever I talk to a pregnant patient, I want to talk about what is the long-term risk of their medical condition based on pregnancy, what's the maternal risk, what's the fetal risk, and then what's our plan. So long-term risk of pregnancy is, I always tell them that pregnancy is a natural weight gaining process, okay? It's normal to gain weight in pregnancy. But what I emphasize to them is that you are probably already have a good amount of weight. You don't need to gain too much weight. And the more weight you gain, the more difficult it's going to be to get back to a normal weight. So a lot of women come to us, BMIs of 35, they know they need to lose weight. And so I tell them, I was like, you don't want to gain too much weight, because the more weight you're going to gain, the harder it is to get to your ideal weight of less than a BMI of 30. And so then we have like these maternal risk, and man, there's a lot. We have diabetes in pregnancy or gestational diabetes. We have hypertensive disease of pregnancy, preeclampsia being the most common. We have obstructive sleep apnea. This is something we're seeing so much more in our more morbid and super morbid obese patient population, that's actually leading to hypertensive disease in pregnancy. They're at a higher risk of having anxiety, and anxiety is not good for a pregnancy. And sadly, what we see is that women that are obese tend to outproportion women that are not obese in the death category. And this is likely related to underlying other comorbidities, but it is associated with obesity in and of itself. From an actual obstetric standpoint, during delivery, they're going to have anesthesia difficulties. The epidural is going to be a lot more difficult. The spinal, if they're undergoing a C-section, is going to be a lot more difficult. And if they have to be intubated, they're at incredibly high risk of aspiration or other obstetrical complications, anesthesia complications. They're likely to have a dysfunctional labor, and whenever you have dysfunctional labor, you can't contract, you can't dilate, and you can't have a normal vaginal delivery. This in turn leads to cesarean sections. So it's very common for obese women. A baseline primary cesarean rate should be about 20%, and obese women is probably closer to 30%. Just because we can't get them enough medication to help them contract and deliver a baby appropriately. And then postpartum, they're at increased risk of wound infections, blood clots, and then postpartum depression. Risk to the baby of a woman who's obese. They have a higher risk of congenital anomalies. This is usually about 2 to 3 times higher in women with congenital anomalies. And because of that, I see all obese women that have BMIs over 35 or 40 for a detailed ultrasound, just because I'm looking more closely, because there's a much higher risk of them having some kind of cardiac or neural tube defect. They're more likely to have multiples, and multiples bring a whole matter of complications in and of itself. But because they're having more trouble ovulating, when they do ovulate, they likely ovulate two eggs, and so therefore they end up with multiples. They're more likely to have preterm birth, and this isn't just spontaneous, this is indicated too. And preterm birth is the highest morbidity and mortality for fetuses or neonates, and so therefore something that they're definitely at increased risk for. And then finally, stillbirth. Lots of reasons for this, not any one determined, but what we know is that obese women, especially super morbid obese women, very, very high risk of stillbirth compared to the general population. But even if they don't have any of these major complications, they can still have neonatal complications. These babies tend to be bigger, and that probably has to do with too much glucose, hyperinsulinemia in these obese women. But the babies tend to be bigger, and that creates problems whenever they're born, like jaundice and hypoglycemia. They tend to have an increased risk of more severe complications like HIE, which can lead to cerebral palsy and other problems. That they need to be on more ventilator support, and in turn, because of these, they're more likely to experience neonatal death in the first 30 days of life. And then long term, a lot of research going into fetal genomics, and for whatever reason, they're at an increased risk of asthma, and not just like the inflammatory respiratory disease, but actually true asthma that can result in hospitalization. And then there's an increased risk of childhood obesity, which just perpetuates the cycle for when they develop a baby, they're going to get worse and worse, and then neurodevelopmental delays. So what we kind of do as contraindications is we basically tell them, if you have a BMI of, ideally you want your BMI to be less than 30 before you attempt pregnancy. And that's to minimize complications. And really we've kind of created a hard and fast rule within the reproductive endocrinology and MFM is that we really don't recommend, and neither do infertility doctors recommend, artificial reproductive technology techniques with our morbid obese women of BMIs greater than 40. So what do we do for pregnancy? Honestly, we don't do a lot. We kind of just tell them that we know any weight that you can lose prior to pregnancy is ideal, so lose that. We really try to limit their weight gain to less than 20 pounds. And honestly, for a lot of my women, as long as the fetus is growing appropriately, I recommend they don't gain any weight. Just kind of let them just kind of maintain their weight and they'll do fine. This is really hard for these women because most of them don't experience any kind of exercise, but the recommendation is exercise light to moderate, 30 minutes a day, 4 to 5 days a week. I kind of reason with them that if they can do it 3 times a week of a brisk walk, or for 15 minutes, that actually is not as good as this, but it's still better than nothing. Can't overemphasize the cardiovascular support that provides in pregnancy and labor. We already mentioned we do a detailed anatomy scan with us, and then really we don't want them delivering early. We want them to deliver at their full term, greater than 39 weeks, in order to minimize the most neonatal complications. And just briefly, want to just mention the idea of bariatric surgery, because a lot of these women, before they get pregnant, they come to us and it's a discussion of, well, would a gastric sleeve or gastric bypass be advantageous? And the truth is, yes, it would be, because even though all women that were obese with history of bariatric surgery or women that are normal weight bariatric surgery, we tell them all your risk are increased compared to normal weight women, but they're all decreased compared to obese women or women with a higher BMI. And so we typically encourage women to undergo those procedures before pregnancy in order to optimize their pregnancy and neonatal outcome. Really what we kind of do, what we tell them though is that make sure you've lost all the weight you want to lose, because once you get pregnant, you're going to be unlikely to lose all the weight that you've already lost. So just be aware that you're probably not going to gain much more weight after bariatric surgery after pregnancy. Maternal risk is really, these are mainly associated with like the Roux-en-Y bypass, but you're going to have anemia due to B12 deficiency, other nutrients, so they're going to have to be on supplementation. Intestinal herniation, just due to the scar tissue and having an acute abdomen, that can result from either a bowel obstruction or a GI hemorrhage. Fortunately, I've only seen one of these in my career, but I have seen it, and it was pretty tough diagnosis, because it can hide itself as just normal pregnancy pain, but you got to have that suspicion in a woman with bariatric surgery. Neonatal child risk, it's basically kind of the same: preterm birth, and the associated risk of prematurity. And these babies are actually at risk of being a little bit small, and that's because of the nutrient deficiency. There's really no contraindications, and so really what we tell patients is, you got to let us know if you're having abdominal pain, and we got to give you a closer look around than just a woman that hasn't had bariatric surgery. Don't lose any more weight during pregnancy, even though you'll want to. Kind of similar to pregnant obese women, don't gain more than 20 pounds. You need to be on nutrient supplementation. A lot of time we have them meet with a nutritionist to go over these things. And then we want to measure the growth very closely. We'll get maybe 1 or 2 extra ultrasounds kind of later in pregnancy to make sure that the fetal growth is not stunted. And just like the other ones, we want them to deliver as close to their due date as possible. So the next big one, as far as the triad, is chronic hypertension. Now this is defined, we define chronic hypertension a little bit different than the new definitions from the AHA. And we define it as blood pressure is greater than 140/90. This is how hypertension was historically, how it was previously defined, and we have not changed our definition in pregnancy. And at this point in time, I don't think we have any indication, we're not planning on doing it anytime in the future. And so if they have high blood pressure, or if they have normal blood pressure but they're already on an antihypertensive medication to help with that, with no obvious secondary cause, then we call that a chronic hypertension. If the blood pressure elevation occurs during pregnancy, specifically in the second half of pregnancy, this is more diagnostic of a pregnancy, hypertensive disease in pregnancy, like a gestational hypertension, and kind of a precursor to preeclampsia, which has a totally different algorithm for treatment and management. This is pretty common, complicates about 5% of all pregnancies. And like I said, at least in my patient population, this is at least probably 20-25%. The risk of adverse outcomes progresses with higher baseline blood pressure and or the presence of end organ damage. So similar to obesity, the worse the hypertension or the worse the end organ complication already is, the worse the pregnancy outcomes are likely to be. Long-term risk of pregnancy, really they're going to get a reprieve. Like their blood pressure is going to be lower in the first and second trimester, so they're actually going to feel great. Sometimes we actually have to DC their medication or go down on it, but then by the third trimester, it's going to go much higher and typically higher than their baseline. But really, if they have already end organ complications, they already have a chronic hypertension with chronic kidney disease, their blood pressure control is going to be very difficult, and they're going to have likely the severe range blood pressure sooner than they realize. The maternal risk is basically when you have chronic hypertension, you have a risk of having preeclampsia, or you have and really the best way to put that is you have an underlying blood pressure, you have a 40% chance of having worsening blood pressures due to pregnancy at almost 50% of the time. And then if they get super high, you're going to at increased risk of having placental abruption, which can be devastating to both mom and to the fetus. Not only that, this tends to result in an increased risk of cesarean delivery due to the superimposed preeclampsia in an early gestational age. But the main risk is really to the fetus, to the neonate. They're at an increased risk of anomalies, not so much due to the underlying disease, but just to the medications that they're on. If the mom was on a medication, specifically an ACE inhibitor, they're at an increased risk of being growth restricted, and if they're extremely growth restricted, that can lead to very much pregnancy complications such as fetal death. They're at increased risk of having preterm birth due to uncontrolled blood pressures and the associated risk of prematurity. And then, like I said, if the baby is too small or just not growing, they're at increased risk of stillbirth. These babies, when they're born, typically tend to be low birth weight, which can result in complications in pregnancy, in neonatal periods such as hypothermia and neonatal seizures, and then that's also ICU admissions and potentially death within the first 30 days. So really kind of contraindications or people we tell not to get pregnant are those that have persistent elevated blood pressures, and specifically of the diastolic BPs if it's greater than 110, or they're on multiple agents, 2 or 3 agents. We tell them, please don't get pregnant. Pregnancy is just going to make your complications even worse, and so we recommend pursuing alternative avenues of childbearing. If you have serum creatinine greater than 2, we don't want you getting pregnant. Your risk of preeclampsia is over 90%, which can result in very scary outcomes, not only for you but also for your baby. Or if they have a history of a cardiovascular or cerebrovascular disease attributed to hypertension. So if they had an MI or a stroke due to hypertension, we recommend actually not being pregnant. Now, these are all relative, meaning that if a mom wants to pursue pregnancy, even with these risks, we're not going to tell her no. We're just going to tell her that she's going to have a complicated pregnancy. She's not going to have an ideal outcome. We're just going to hope to give her the best outcome that we possibly can. So how do we manage these? Well, we want to just kind of start from the beginning. We want to assess the underlying kidney function. And this is going to help us distinguish from physiologic changes from preeclampsia. So as I mentioned, a little bit of proteinuria is normal in pregnancy, but too much proteinuria is not. And so we want to assess and make sure that they don't have just already gross proteinuria from poor kidney function prior to pregnancy. We want them to be on aspirin because aspirin is one of the only things that's been proven to decrease the risk of preeclampsia. If they have a long-standing history or they have known heart disease, we want to make sure that their heart is intact. Pregnancy is hard on the heart, especially an already damaged heart, and so we want to make sure that that heart functions normal. We want them to stop an ACE inhibitor. It's contraindicated in pregnancy, increased risk of fetal anomalies, specifically of the kidneys, and we want them to transition to something with a better safety profile. Labetalol or nifedipine are kind of our preferences for that. These aren't the best blood pressure medications outside of pregnancy, but within pregnancy, they do a very good job for us. We want their blood pressures to be we want them to be controlled. We want them to be less than 160/110, and if they already have end organ damage or kidney damage, we want to be more aggressive and less than 140/90. Just as far as just a note, there's a trial going on for which UAB is kind of the headline site, but it's going on all over the country. I believe it's 70 or 80 sites. That's basically measuring right now if we should be it's actually asking the question, should we be treating more mild hypertension? Should women that have hypertension, 140s, 150s, systolic, should they be on meds versus should we expectantly manage? Because what you run into the problem, if your blood pressure is too low, you don't get enough placental perfusion and you have increased risk of small baby or poor placental perfusion that can lead to other acid-base status and complications. So there's a trial that's still trying to answer this question. My guess is it's probably going to be non-conclusive and it's not going to make any difference, but we'll see what the results say. Hopefully it's done in the next year or two. We're going to do a detailed anatomy scan due to the increased risk of complications. We're going to not only assess the growth of this baby in the third trimester, we're also going to perform antenatal testing to try and make sure that there's not an increased, no early signs of fetal distress that could result in stillbirth. And then just like the other, and we want these babies to go as far along as possible, unless there's already end organ damage and we're almost certain it's going to lead to a poor outcome like preeclampsia or stillbirth, we may deliver them a month early. Last in the triad is the pregestational diabetes. And we kind of look at this in two categories. We look at this both as pregestational or gestational. And pregestational, there's both type 1, type 2, and then we actually also identify are there vascular complications or are there non-vascular complications, and specifically with one. So is this a type 2 diabetic with underlying kidney disease? Is this a type 1 diabetic with retinopathy? And so that's kind of how we divide it, because that has different strategies for how we not only manage it, but also how when we kind of intervene and deliver for complications. This complicates up to 4% of all pregnancies, and honestly it's probably closer to 6 to 7%. That data is about 8 years old. And this just keeps going up and up. I mean, we're to the point we're going to start developing our own diabetes clinics that are going to be full 2 days a week, just because this is such a common occurrence in pregnancy. And really, I think this is a good thing to know, is that just the degree of underlying cardiovascular or renal compromise is more important than blood sugar control in determining the risk of adverse pregnancy outcomes. And so, put another way, if a woman comes to us that already has heart disease, kidney disease, eye disease, it really doesn't matter how good we get their blood sugars, they're still at such a high risk of adverse pregnancy outcomes. And so we treat them we keep even a closer eye on them, just because it's not a matter of if something adverse is going to happen, it's just a matter of when. So for those that want to get pregnant or are pregnant that have diabetes, we always basically mention that if there's any end organ complication present, it's probably going to worsen during pregnancy, especially if you have suboptimal glucose control. So if you have a patient with retinopathy already and they can't get control of their blood sugars with pregnancy, which we already talked about is going to be hard because it's a fasting hypoglycemic and a postprandial hyperglycemic, that retinopathy is gonna worsen over time, and it's going to hasten how quickly it's going to worsen. And so that's just something that we let them know about. And we also let them know that, hey, if your blood sugars are hard to control outside of pregnancy, they're going to be even harder to control inside of pregnancy. Maybe you have a great control of your blood sugars in pregnancy or outside of pregnancy. In pregnancy, it may be difficult just because of the natural physiologic state. Women, especially type 1s, really increased risk of going into DKA, and they can go into DKA at low values. I've seen a lady go into DKA with a random blood sugar of 170 just last week, and so it's very common for them to go into DKA. They're at increased risk of getting preeclampsia. There's lots of reasons for why that's the case, but definitely something to look out for. An increased risk of having a lot of fluid, and if you have a lot of fluid or polyhydramnios, increased risk of maternal discomfort, preterm labor, things along those lines. And and these women also had increased risk of cesarean delivery due to, preterm delivery or just obstetrical complications that result in us needing to get deliver a baby earlier. Just like the other ones, increased risk of anomalies, specific cardiac and neural tubes. They have as high a risk as about 3 to 4% of cardiac defects. So we actually do something special for them. Just like a kind of interesting, similar to obesity and similar to chronic hypertension, both these babies are at increased risk of being restricted and also at increased risk of being too big. And so it's one of these things where you can't get it right. Either they're too big or too small, so you just got to look for it at both. They're also at an increased risk of being born early in stillbirth, similar to other complications. Once they're born, they're at increased risk of being large for gestational age, small for gestational age. If they're too big, that's when we get into problems with birth trauma. These birth traumas are typically things like shoulder dystocias or broken clavicles, broken long bones, just due to facilitating a natural birth. And even in a cesarean section, they still can be difficult to deliver just because their body composition is much different. They're bigger in the shoulders and the abdomen, smaller in the head, which just causes the delivery to be a little bit more challenging. They're at increased risk of respiratory distress, so a lot of them have to have oxygen support through a CPAP or immediately after birth, and many have to be intubated if they're born very preterm, just because of that. Polycythemia, hyperinsulinemia, which can result in hypoglycemia, hypocalcemia, and hyperbilirubinemia. All this to say is our pediatric oncologists don't love us to deliver premature neonates of diabetic women because they're very difficult to manage in the ICU setting, especially uncontrolled. And then long-term complications, increased risk of obesity and actually developing type 2 diabetes themselves. So similar to hypertension, we have some relative contraindications. Continual end organ damage due to uncontrolled or difficult to control sugar, we basically say, please don't get pregnant. It's just going to be very difficult for you to get good control over your blood sugars, and that can result in some poor outcomes. And then ideally, we really want them to have well-controlled diabetes to help minimize the risk of congenital anomalies, and just getting them a habit of having good control over their sugars with an A1C of less than 6.5. So how do we manage them? We want them to see a diabetic educator and nutritionist where they can discuss dietary changes for pregnancy. A lot of them are used to carb counting or having a carb-limited diet in order to regulate their blood sugars. We don't want that. We want them to have a well-balanced diet. We just want them to make sure that they're not overindulging in sweets and sugars. Tight glycemic control, we want them checking their blood sugars at least 4 times a day, sometimes 7 times a day before and after all meals. And we have pretty tight goals. Typically, like a lot of our endocrinologists kind of are, they don't like us to have as tight of goals because they worry about hypoglycemia, which we do too. But what we know is that if the fasting is greater than 95 or the postprandial is greater than 140 at an hour or 120 2 hours after a meal, the risk of fetal and neonatal complications is not good because we're taking care of 2 patients. We're taking care of a fetus that's going to be a neonate after birth, and we're trying to minimize the short-term and long-term complications of that pregnancy. And in order to do that, you have to have tight glycemic control. If they have a 10-year history, or really, this probably less. We're probably going to change this to maybe 2 to 5 year history. We want to get an EKG or maybe even echo, just because the risk of underlying heart disease is so high. We want to do a detailed anatomy scan with an MFM, but then we actually do a fetal echocardiogram because the risk of congenital heart disease is so high in these patients. We actually do a screening fetal echo with either ourselves or one of our cardiology colleagues to look at the heart beforehand, just to make sure there's not any severe congenital heart anomaly. Similar to chronic hypertensives, we get a fetal growth ultrasound and we antenatal test them, looking for signs of fetal distress early, kind of in the 3rd trimester. And this is where we really individualize care. If they're well controlled, we want them to go full term to minimize the complications of early term delivery, 37, 38 weeks. But honestly, many of these, they're difficult to control, and their risk of preeclampsia is either there or it's so high, and that's going to lead to complications that we deliver them in the early term, 37 to 38 weeks. So how can you, kind of as non-obstetricians or people that don't see pregnant women, how can you help improve these pregnancy outcomes? And so I have a couple of things here, and really it's support appropriate medical use and reestablish care as soon as possible. And so you have these common medications to avoid. And I think a lot of times when people are taking care of pregnant women, they really want to make sure that they're taking care of the fetus and the neonate by not exposing that to medication. So they just tell mom to stop taking medication. And that's the wrong approach. Most medications are actually safe in pregnancy. And we'll talk about why that's the case in a second. But these medications are not. These are known to be teratogenic and harmful. Thalidomide, Very harmful. Luckily, this is not much given anymore, but if the pregnant lady is on this, they need to be off of it immediately. Isotretinoin or Accutane. A woman should not be on this medication and planning to get pregnant. If they have methotrexate for maybe a rheumatologic condition, they should not get pregnant. If they do get pregnant, they need to stop methotrexate and find an alternative medication immediately. I already mentioned ACE inhibitors and ARBs. If they're on hormone replacement therapy, maybe they had their ovaries removed for some kind of cancer, and so they're on hormone replacement therapy. They really don't need to be on that during pregnancy, and they don't need to be on clearly don't need to be on contraceptions while they're getting pregnant. So former medication categories. This is how we used to talk about medications. You had these categories. You had A, B, C, D, and X, okay? A was controlled studies that showed no risk of or found no evidence of harm. I can't think of any medications that were category A, okay? But that was there. B was basically animal studies showed no risk, but there were no controlled studies on pregnant women. C was there was no animal studies showed no risk, but there was no controlled studies on pregnant women, or studies on animals and women were not available. D showed that there was potential harm, and X showed there was definite harm, okay? So I don't want you to keep this in mind, all right? So the problem with the categories is most of these medications got put into category C because there was limited studies of pregnant women. I'd be remiss if I don't mention the COVID study, for instance, right? Huge vaccine trial with a pandemic going on, pregnant women were excluded, okay? Well, reasons for that, okay, whether they're good or bad and where you fall on that is one thing, but the truth of the matter is we have no data on pregnant women. So just today I spoke to 3 pregnant women about should they get the COVID vaccine. And my response is, we think it's safe, there's been no data. And that's kind of what was happening with these categories, with category C, was we said, hey, we think this medication's safe, but we really don't know. And the problem is a lot of these medications are really important for pregnant women to be on. It's really important that pregnant women get the COVID vaccine if it's safe. The problem is we just don't know that it is. And so there's a big push right now for us to enroll well-informed and women that want to be enrolled in trials into these trials so we can get data on it to make sure that we're giving women medications that they need and that are going to help improve fetal outcomes, neonatal outcomes as well, and get things off the market that potentially can cause harm, okay? The other problem with these categories is you had this idea of certain medications could switch classes due to new findings. And so, and this is just one example of magnesium sulfate. So this was actually one medication that was a category A, okay? But then it got moved to category D. The reason it got moved to category D is because when it's used more than 5 days in a row, it's associated with neonatal hypocalcemia and bone fractures. Okay, if I have a medication that is going to cause that, I don't want a pregnant woman on that because I don't want my neonate to have those problems after birth. Well, the problem is magnesium sulfate is actually very beneficial for the neonate. When we have a woman that we think is going to deliver before 32 weeks, if they get limited amount of magnesium, that protects them against cerebral palsy. So how do you weigh this pro-con of, well, it can be harmful, but it's not harmful. Or it can be helpful and it can be harmful. And so that was the whole thing, is like magnesium sulfate, you can't say it's A and D. You have to put it in category, even though depending on how you use it, depends on if it's beneficial or harmful. And really this just brings me to the point of individualized care wasn't taken into considerations in these categories. So I not to use an example, a morbid example, but I got to say, so lithium, category D, increased risk of heart defects, not a good medication. The problem is that most women that are on lithium are on it because they can't be on anything else. I've had a patient that basically got off of her lithium, had uncontrolled bipolar, and attempted suicide numerous times. That's not healthy for the baby, and that's certainly not healthy for the mom. And so really, probably her staying on her lithium, even though there's a known risk to fetal harm, would have been beneficial for both her and the baby, because if she commits suicide, there's 2 deaths, okay, as opposed to potentially 1 anomaly. And so that's just one example of where you really do have to individualize this care, and the categories wouldn't let you do that. So this is just an example of what we do now. So, and I'm just kind of going to read this, is warfarin, a category X medication. Actually, there's a whole syndrome called Warfarin syndrome that creates lots of problems. We do not recommend this in pregnancy. So how do I counsel a patient? I basically say there's a 3% risk of vaginal anomalies, but only 1% of those is really related to medications, specific agents. However, it's really difficult to determine what medication is safe in pregnancy, and as infants who are exposed are rarely really even monitored throughout their lives. So we just have short-term data, not long-term data. And regarding warfarin, its use does increase the risk of structural malformations when used in the early part of pregnancy during organogenesis, first trimester. Other adverse pregnancy outcomes such as hemorrhage and intracranial fetal bleeding can also occur with this medication. Its use should be limited in cases at risk of severe maternal mortality or morbidity, such as women with mechanical heart valves. And so what we do is we put a lady who has a mechanical heart valve, which we have numerous in our clinic, we put them on Lovenox during the first trimester, and then we switch them to warfarin. We've individualized care, and we've used a medication that we think is going to be safe in pregnancy without doing much harm. And you can't do that when you have these classifications of drugs. So what do? Just don't stop a medication just because a woman's pregnant. That's all I'm saying. Unless it's one of those that's always avoided, don't stop a medication just because a woman's pregnant. Most medications aren't considered safe in pregnancy just because there's lack of data. I can't emphasize this enough. It's not that these medications are harm, there's just no data. And the data is probably okay, because if it wasn't okay, you'd have tons of lawsuits popping up from these women that were on these medications, and they would take these off the market immediately because they couldn't afford to have them, okay? If another thing is that if there is an alternative of something that's been studied and not, then switch. We had a lot, Xarelto was used for a lot of women that had a history of VTEs. There was no pregnancy data on it. Well, we kind of said it was probably okay for them to be on it, but we know there's safety data in Lovenox, so let's switch them to Lovenox. And so that's what we would recommend happening. And then if there's no alternatives with the known safety profile, just tell them to keep on it and see an obstetrician as soon as they can so they can discuss this with them. And just really, if you have any medication questions, don't hesitate to ask an obstetrician. They don't have to be a high-risk pregnancy doctor. Most obstetricians know what medications they should be on or not. And if they don't, they'll ask their MFM or talk to someone that knows. The final other things y'all can do is just this idea of postpartum follow-up. This fourth trimester has kind of gotten a lot of attention as far as pregnancy, and pregnancy complications doesn't just end after discharge from hospitalization. It actually ends, a year after delivery. And really that's because there's a lot of challenges, especially for first-time moms in this postpartum period. There's the caring for the newborn. There's the lack of sleep. There's breastfeeding difficulties. There's the postpartum pain. There's the stress of having a newborn and caring for it and bringing it into this world during a crazy time. All this stuff is very challenging for these women and potentially can be harmful for the neonate as well, and so they must be addressed. And so the problem is women that already have medical complications, now they have these and they have their medical complication that they have to worry about. They have diabetes, they have uncontrolled blood pressure, they are morbidly obese, and they've gained 30 more pounds on top of what they already had. And so it's just something that can be very, very stressful and very difficult for women. So postpartum follow-up is getting a lot of attention to where we're recommending women be seen really, or I should say, not we yet, but the obstetricians and advocates are recommending that these women be seen at least twice in the postpartum period, and maybe even 3 times, depending on their medical comorbidities. And these physiologic changes of pregnancy, that idea of progesterone, they typically resolve within the first 2 to 3 months, but sometimes they can last as long as 6 months, which can result in some of those complications. And so what do we recommend for these follow-ups? It's really, we have 2 jobs. We have jobs as obstetricians and then jobs as non-obstetricians. And so obstetricians, we got to counsel patients on the pregnancy complications and implications for future childbearing and long-term maternal health. So hey, you had diabetes and high blood pressure and got preeclampsia. What does that mean for your next pregnancy? What does that mean for the rest of your life? And really what we have to be is we have to really emphasize the importance of, hey, your diabetes doesn't just go away when you have a baby. It's a lifelong condition that needs management so you can be there, and be in good health to see your kids and see your grandkids as they get older. And then primary care providers, they must review and discuss medication selection and dose outside of pregnancy. That means talking to your patients of reproductive age. Are they thinking about having a child? If they are, do we need to switch medications? And those that have already had babies, it's basically like, hey, are you breastfeeding? If you are, this is probably a good medication for you to be on. We try to address that as obstetricians, but oftentimes there's some women that breastfeed for 6 months to a year. Greater than 6 months to a year that we don't have follow-up with anymore that needs to be on a medication. And then also knowing when there are appropriate referrals to improve patients' overall well-being. So a patient that's morbidly obese, referral to a weight loss clinic. Referral to an exercise program to help facilitate that and help improve their blood sugar control and diabetes, and mental health programs. So I guess just, to kind of close up, I put this at most of my end of my multidisciplinary talks because really it takes a village to us to treat these women. We're just treating them during this small little window that has obviously lifelong implications, but it takes all of us to really improve our patient's health and our patient's life. And so it's something that we just got to work on together and help each other out. So, most of this is just taken from our basic text and updated practice guidelines. And I don't have my email on here. I think I had it at the beginning. But if you have any questions or any comments, please feel free to email me. It's ccollier, see my last name, at uabmc.edu, and I'm happy to take those. So thank you all very much.